I now request Dr. Sumana to please take over and present her talk on conservative management, non-surgical strategies in acute eye drops management. Thank you, Dr. Sumana.
Thanks, Dr. Purvasa. A very good morning to all of you. And it's an honor to be here. I give thanks to AIOS and Dr. Jayagupta and Dr. Purvasa for roping me in. So after the fantastic talk that Dr. Purvasa gave, I will talk a few things about the conservative management strategies in acute eye drops. So as she told, it's a self-limiting condition and generally resolves without intervention in weeks to months. So actually conservative management aims to provide symptomatic relief and promotes spontaneous resolution of eye drops via aqueous suppressants, steroids and hyperosmotic agents. We can manage the pain and photophobia with the use of bandage contact lens, cycloplegic agents, dark glasses and NSAIDs. There is a definite role of broad spectrum antibiotics to prevent the secondary infections, particularly when the epithelium is compromised and if BCL is used. The another role of anti-glaucoma medication being to lessen the hydrodynamic force on the posterior cornea. The risk of infectious keratitis, as Dr. Purvasa has already told about the settle positivity, and it's not only about the rupture, it's the transudation of aqueous through the edematous cornea instead of perforation, and we do use aqueous suppressant and pressure patching for these cases. And if there is bullous rupture of the corneal surface, it exposes the raw stroma to the tear film and ocular commensals. Along with that, poor hygiene may lead to infectious keratitis. So we have to be judicious in our use of topical steroids. This is one of my patients, a little kid, who came to me with the acute eye drops, and we are getting ready for the GA fitness and all. In the meantime, within 3-4 days, he came with this pseudomonas ulcer. And we did have a stormy weeks but fortunately it healed with medications, but it left an ugly scar. So we had to resort to a penetrating keratoplasty for visual recovery. And the second one being corneal neovascularization during resolution. It is a serious concern when the site of eye drops is actually near the limbal vasculature. And this response may begin 2 to 4 weeks after the onset of eye drops. Steroid is again the savior in these cases. And there is a definite role of contact lenses, because once the area of eye drops resolves, the previous ectatic area becomes flatter, and so vision may actually be better than prior to onset. So RGP lenses may be easier to fit with a new flatter curvature, and we are resorting to post-eye drops fitting with scleral contact lens, which actually bridges the patient's unique corneal curvature. So this is the same kid. Unfortunately, in the second eye also he had a eye drops. But the parents, after the stormy episode of the other eye, they didn't want second pneumatic desmetopexy also. So we treated him with medical management, and post-resolution 3 months, his vision with miniscleral lenses did improve to 6/9. We resort to pneumatic desmetopexy early, not only when there is persistence of eye drops despite conservative measures, and the first-line intervention includes the intracameral injection of air, or 20% SF6 or 14% C3F8. The choice between air and gas depends on the estimated amount of time needed to repair the defect in Descemet's membrane. Air, being the shortest duration, may require repeat bubble placement to achieve the desired effect. SF6 is usually retained for 7 to 10 days, and C3F8 retained for almost 6 weeks. So the purpose of pneumatic desmetopexy being creating a barrier to prevent the aqueous humor from passing through the ruptured descemetes into the stroma, allow for faster healing of the endothelial cells over the exposed stroma, and deposition of the new Descemet's membrane, as Dr. Purvasa has already discussed. So DM has to reattach to the posterior stroma, and time for this stage depends on the depth of the DM detachment. The second one being endothelium has to migrate the gap and synthesize a new DM. Time required for this second step depends on the scale of the DM break. So pneumatic desmetopexy can hasten the DM retachment to the posterior stroma in the first step, but it doesn't help in the second one. So it can tamponate small to medium sized breaks only and promote more rapid wound healing of corneal endothelial cells. And in larger breaks, the risk of the bubble traversing into the fluid cleft and failing to form a secure tamponade is always there. So these are the clefts where they are usually connected to the anterior chamber by small gaps through which the gas can easily enter into the corneal clefts. So this type of cases requires multiple gas injection, and this mode of treatment may not be sufficient alone. So what needs to be done will be discussed by the other speakers. So the size, location and amount of edema should dictate which method of treatment would be most effective. If the hydrops is off-center and patient complaints are minimal, we can take a conservative approach of topical therapy. But pneumatic desmetopexy always results in quicker recovery. It shortens the period of discomfort and poor vision. It theoretically decreases the risk of visually significant scarring and need for post-resolution corneal transplant. But there are complications like pupillary glaucoma, Uris-Javallia syndrome, stromal cleft, and the accidental seepage of the air bubbles, giving it a fish-egg appearance, so nullifying the tamponade effect fully. So as Dr. Somshila Madam will discuss later on, the intracameral gas should be introduced along the iris plane and in a single bubble, and inferior surgical PI is recommended to prevent any episode of acute congestive glaucoma. Thank you so much for your patient hearing.